Good morning, distinguished chair, dear colleagues and reviewers. My name is Mure Ali, and I'm co-author with dear Huaicong Long. Today, it's my great honor to present our study titled Chronic Lung Disease and Frailty, a longitudinal analysis of bidirectional associations using CHARLS and our Chengdu cohort. First, let me introduce our team. This work was completed under the supervision of Professor Huaicong Long, together with Ziyi He, Judge Liu, and me. Professor Long is a professor and director of the Division of ICU in the Department of Gerontology at Sichuan Provincial People's Hospital, with rich experience in geriatric and critical care medicine. I'm a postgraduate student at Chengdu University of Traditional Chinese Medicine, and also a research member at the Sichuan Provincial People's Hospital, University of Electronic Science and Technology of China. We have no disclosures. Today, I will briefly introduce our study in 6 parts: background and research gap, study aims and hypotheses, study design and methods, main results, mechanism and clinical implication, conclusions and acknowledgements. First, let's talk about frailty. Frailty is a common geriatric syndrome characterized by reduced physiological reserve and increased vulnerability to stressors. It strongly links to force, disability, hospitalization, and even mortality with globally aging. Frailty has become an important public health challenge. Next, chronic lung disease, including COPD, chronic bronchitis, emphysema, and pneumonia, is one of the top 5 leading causes of this worldwide. It's highly prevalent in older adults and places a heavy burden on individuals and healthcare systems. Notably, CLD and geriatric syndromes are often coexist. The bidirectional negative effects accelerate functional decline, but this relationship is still underestimated and understudied. Based on the above background, we found 3 critical research gaps. The first, no study has confirmed a bidirectional relationship between frailty and CLD. The second, how dynamic frailty changes affect CLD risk remains unknown. The third, whether early frailty intervention can prevent CLD has not been explored. Therefore, we proposed our hypothesis. The first, there is a bidirectional relationship between frailty and CLD. The second, changes in frailty status will affect risk of CLD. The third, frailty intervention can prevent incidence of CLD. Our study had 4 main aims: to explore the effect of baseline frailty status on the incidence of chronic lung disease in older adults, to explore the impact of CLD on the longitudinal progression and the worsening of frailty over time, to protect the association between dynamic frailty transitions and future CLD risk, to validate our findings using an independent Chengdu cohort. We used 2 cohorts: CHARLS cohort, a national prospective longitudinal study from 2011 to 2020 with a 9-year follow-up. We applied weighted regression, logistic regression, and other methods. Chengdu cohort, an independent community-based validation cohort from 2022 to 2024. After strict inclusion and exclusion criteria, we finally included 3,544 participants in the CHARLS cohort and 670 participants in the Chengdu cohort. All participants were aged 60 years or older, with complete Frailty index and covariate data. We used a 30-item Frailty index to assess frailty and classified participants into robust, pre-frailty, and frailty group. CLD was defined as doctor-diagnosed COPD, chronic bronchitis, emphysema, or core pulmonary. We also adjusted for major confounders, including age, sex, smoking status, and living area. This table shows the baseline characteristics of the CHARLS cohort. We can see that frail participants were older, more likely to be female, living in rural areas, and have lower education levels, which is consistent with previous studies. The table summarized baseline characteristics across the Chengdu cohort, revealing high consistency with the CHARLS cohort. The high consistency in baseline trends between the Chengdu cohort and the national CHARLS cohort establishes strong comparability and provides a solid methodological basis for subsequent external validation studies. Our first main result in the 9-year follow-up of CHARLS pre-frailty was associated with 67% higher risk of CLD incidence, and frailty was associated with a 169% higher risk. We found a clear dose-response relationship between frailty severity and CLD risk. We use Kaplan-Meier survival curves to evaluate mortality risk by frailty status among CLD patients. Survival differed significantly across robust, pre-frail, and frail groups, with the frail group showing the highest mortality risk. Moreover, CLD notably worsened survival outcomes in frail individuals. In the independent Chengdu validation cohort, pre-frailty and frailty were associated with 3.47-fold and 4.12-fold highest odds of CLD, respectively. The results were highly consistent with the CHARLS cohort, which strongly validates our findings. On our third result, among patients with existing chronic lung disease, pre-frail status and baseline independently predicted progression to frailty, with a 3.43-fold higher risk. This indicates that pre-frailty is a strong predictor of frailty progression in CLD patients. Here, we look at frailty transitions and CLD risk in the CHARLS cohort. Worsening frailty significantly increased CLD risk by 71%. Improving frailty significantly reduces CLD risk by 51 to 75%. Concluding, dynamic improvement in frailty status is associated with substantially lower future CLD risk, highlighting the potential benefit of frailty intervention. The bidirectional association may be explained by shared mechanisms. Frailty can lead to CLD through inflammation, reduced immune function, and respiratory muscle dysfunction. Conversely, CLD can lead to frailty through chronic hypoxia, systemic inflammation, reduced physical activity, and malnutrition. Our study has important clinical implications. First, frailty screening should be integrated into routine assessment for older adults at high risk of CLD. CLD patients need regular frailty monitoring with early intervention for pre-frailty to prevent progression. Improving frailty can reduce CLD risk, providing a novel and effective target for future preventive strategies. Highlights the importance of comprehensive person-centered health management in the general older population. The strengths of our study include two cohort design, longitudinal data, external validation, bidirectional analysis. Their limitations include self-reported CLD diagnosis, measured confounders, limited generalizability. In conclusion, frailty is an independent risk factor for CLD incidence. CLD significantly increased the risk of frailty progression. Dynamic changes in frailty are closely associated with CLD risk. I would like to express my sincere gratitude to the organizing community of the 8th World Aging Conference for the kind invitation. Meanwhile, I also thank the CHARLS research team for participants in the Chengdu cohort, a research group, as well as all sources of funding support. Now, I'm open to your questions. Thank you very much.